Welcome to this explainer on acute appendicitis. We are diving straight into exactly what happens when this tiny organ decides to completely rebel against your body. We'll unpack everything from the very first biological warning signs right through to the operating room and the road to full recovery. Let's get into it. So think about this for a second. 7 to 8% of us are going to face this medical emergency in our lifetime. That is a massive chunk of the population. It most commonly strikes people between the ages of 10 and 30, but honestly, it can happen to anyone at absolutely any age. And when it does hit, it's a true ticking clock emergency, where delaying treatment gets incredibly dangerous. To break this all down, we'll cover 5 key areas today: the appendix under attack, recognizing the warning signs, diagnosis in the ER, treatment involving surgery and meds, and finally, the road to full recovery. Section 1, the appendix under attack, anatomy and obstruction. Okay, so what exactly are we dealing with here? The appendix is this small, finger-like pouch, usually about 6 to 10 centimeters long, attached to the cecum, which is basically the starting line of your large intestine. Now, we used to think of it as just useless evolutionary baggage, but current science shows it actually houses lymphoid tissue for your immune system and acts as a safe house for healthy gut bacteria. But here's the wild part. Its exact position inside the body varies from person to person. It might be tucked behind the colon or hanging down into the pelvis, and that sneaky variable position, it literally changes exactly where a patient might first feel the pain. Here's where things go wrong, and it all starts with a simple blockage. Usually, a hardened piece of stool, a fecalith, or some swollen tissue blocks the entrance. Once it's blocked, the appendix just keeps producing mucus, but that mucus has nowhere to go. The pressure inside skyrockets, the blood supply gets choked off, and common gut bacteria, like E. coli, start throwing a massive party and multiplying rapidly. If left alone, this localized infection turns into gangrene, and eventually the whole thing just bursts, spilling toxic bacteria right into the abdominal cavity. Moving on to Section 2. Recognizing the warning signs, the patient journey. Let's put ourselves in the clinic. Imagine an 18-year-old walking in. They say the pain started a few hours ago as this vague, annoying ache right around their belly button, but now it is migrated sharply to the lower right side of their abdomen. It's one of the most classic yet bizarre features of this condition. Why does the pain literally move? The secret behind this moving pain is all about something called McBurney's point. See, at first, your brain misinterprets the early distress signals from the appendice's visceral nerves as just a general mid-belly ache. But as that little pouch becomes massively swollen and furious, it starts rubbing against and irritating the inner lining of the abdominal wall right above it. Suddenly, the pain localizes sharply to McBurney's point, right in that lower right quadrant. When the pain shifts there, alarm bells should be ringing. It's a true emergency. But pain isn't the whole story. Usually, loss of appetite and nausea hit first, often before the pain even ramps up. Then comes a low-grade fever. What we really have to watch out for, though, are the red flag emergency signs. We're talking a high fever or abdominal rigidity, where the stomach muscles involuntarily tense up like a wooden board. And here is the absolute craziest part. If the patient experiences a sudden, miraculous relief of pain, that's not a recovery. It likely means the tightly stretched appendix just ruptured, releasing the pressure right before a massive, life-threatening internal infection takes over. Section 3. Diagnosis in the ER, narrowing it down. Once they're in the ER, doctors have to play detective, using a differential diagnosis. Is it just gastroenteritis? Well, a simple stomach bug usually brings more generalized cramping and diarrhea. Could it be a kidney stone? That pain usually shoots into the back or groin, maybe with some blood in the urine. To narrow it right down to the appendix, doctors do specific physical checks, like testing for rebound tenderness. That's when the doctor presses down on the abdomen and it actually hurts the patient way more when they suddenly let go. To know for sure, we need to look inside. Imaging is the final piece of the puzzle, but the tool depends on the patient. An ultrasound is amazing because it uses zero radiation, making it the incredibly safe first-line choice for children and pregnant patients. But for most adults, the CT scan is the absolute gold standard. It hands the doctors a highly detailed 3D roadmap to see exactly how angry that appendix is and whether it's already popped. Section 4. Treatment, surgery, and meds. Before anyone even thinks about picking up a scalpel, the medical team goes to work stabilizing the patient. They're pumping IV fluids to maintain hydration and blasting the system with powerful broad-spectrum antibiotics. You've got to start fighting that internal bacterial infection immediately, especially if there's any chance of a leak.
Throw in some pain relievers and anti-nausea meds, and we're getting the patient as stable and comfortable as possible.
When it is time for the appendectomy, surgeons typically take one of two routes. Laparoscopic removal is the gold standard today. We're talking just a few tiny keyhole incisions, a camera, and specialized tools. It means less pain, way lower infection risk, and getting the patient back on their feet faster. But if things have gotten messy inside, like if it's severely ruptured and created a huge abscess, they absolutely have to do an open appendectomy with a larger incision to get in there and safely clean it all out. Section 5. Road to full recovery, physiotherapy and nutrition. Waking up from surgery is just the start of a very specific timeline. Day 1 is all about the basics, sipping clear fluids, doing deep breathing exercises with an incentive spirometer to keep the lungs clear, and just trying to sit up. A few days out, they graduate to soft foods and actually walking around. Fast forward a few weeks, and the focus shifts to core rehab, rebuilding that abdominal strength so they can get back to the gym or demanding work without risking a hernia. You might not immediately connect physiotherapy with having your appendix out, but it's actually huge here. Getting out of bed early and doing targeted leg exercises isn't about getting fit. It is absolutely crucial for preventing highly dangerous complications. We're talking deep vein thrombosis, blood clots in the legs, or lung infections like pneumonia. Literally, moving helps your body heal. Wrapping up this explainer, the biggest takeaway you should keep in mind is this: time is tissue. Appendicitis moves fast. Ignoring a bellyache that shifts and sharpens is playing a very risky game. Catching it early and getting right to the ER is exactly what guarantees those textbook full recoveries. So I'll leave you with this. If that vague, dull ache suddenly starts its sinister march down to your lower right side, will you recognize the ticking clock before it's too late? Listen to your body, know the red flags, and never underestimate what's happening just beneath the surface.